Garni from Aramco Hospital. Sometimes we see a patient with perianal fistula disease, and on MRI there is inflammatory mass, fluid in the pelvis, no clear abscess. What is the approach to this? This question to Dr. Stephen.
The first question is, do you have a complex fistulating disease, yes or no? Because if you have a complex fistulating disease, then you should involve your surgeon, and definitely you should include the abscess anyway by more imaging studies. And if it's just an inflammatory mass and you do not have any abscess, and you do have, say, a moderate system of fistula tracts, and the patient has proven Crohn's disease, which is also important, not tuberculosis, then you may treat that patient indeed with the anti-TNF, I think is the first choice. But then, after the inflammation is calmed down, there has to be fistula in there, because that's the reason for the inflammatory mass, and then I would think it comes together with the surgeon for some planning what to go do next.
Thank you.
Dr. Hamad Shuja', gastroenterologist, King Fahad. My question to Dr. Khalid. Which fistula you think we should refer to you immediately? You will say it is surgical. And what is your criteria that you should go quicker for surgery?
By definition, fistula is a surgical disease to me. And I think it is, to me, it is a team approach. And whenever there is a fistula, the surgeon should be on board. And he should be involved in all cases where there is a fistula. Because the natural history of the fistula, we know, whatever with medical disease you're going to do, 1/3, 1/3, 1/3. Third, they're going to resolve and heal completely. 1/3 will keep just trickling and discharging, and 1/3 will not respond. So in my opinion, it is a team approach, and the surgeon should be on board in all cases where there is a fistulization. And this is actually the practice in our hospital. Every case they refer it to me, and they take my opinion what we going to do with it.
I would like to underscore this, because there's also the simple fistula. The simple fistula is something which everybody can get, even without Crohn's disease. Yeah. And there's a reflex, at least in Germany, to treat these features in infliximab. There's no reason to do so. In most cases, you do nothing, or you do give some antibiotics, or you do a very simple surgical procedure, yeah, and that's it. But that's a simple fistula. That means no branching fistula tracts, yeah, no involvement of the sphincter, a simple fistula.
That's true.
Dr. Nahla?
Yes, thank you for all speakers. My two questions about post-operative recurrence, but we'll take a chance we have the surgeon asking about the surgical technique to prevent post-operative recurrence, although I know it's not in your topic. Second, for Dr. Rahman, how about combination of many medication instead of monotherapy for post-operative?
So maybe I'll just start with the second part. Regarding the treatment with a combination, what I think, Dr. Nahla, you're leading to immunomodulators with anti-TNF therapy. I think what we are seeing at this time, especially with the SONIC trial and the other trials, that using combination is much better. But I don't think there is enough evidence at this moment that using it post-operatively will prevent the recurrence. What we have at this moment, using the anti-TNF by itself, having a good response. But I think in the future, we will see more of that combination. There is also some data I didn't present here, is even using the anti-TNF therapy, even the timing after surgery will make it different than, the response will be a little bit different. There is some study by Yamamoto from Japan, I think. He started anti-TNF therapy 6 months after the surgery, where the recurrent or the endoscopic recurrence was higher than other study where they start the anti-TNF therapy 4 weeks after the surgery itself. Regarding the technique itself, I alluded a little bit about the technique, the surgical technique. As I mentioned before, maybe I'll leave it maybe for the surgeon, but just end-to-end anastomosis is different than end-to-side anastomosis.
Yeah, regarding surgical technique, it depends if we're talking about fistulizing anal Crohn's, is that your question? Or just Crohn's in general? For regarding fistula and Crohn's, I think the most important is to have the roadmap before go to the surgery. You should know, is it low, is it high, is it transsphincteric, suprasphincteric, where it's going, and you should know if there is any concomitant abscess with it, and also not to go very aggressive. These are very general recommendation, not to go very aggressive, and also try to drain the abscesses first, then you should try to put the draining seton. This is for fistula, in particular, anal fistulas in particular, but in Crohn's disease in particular, it's so big, but if you are talking about micro or macro margins, usually we go for macro, not the micro, and we don't take histologic margin, and we go for macroscopic margin.
Okay, last question.
Ahmed Hashim, Saudi German Hospital, Jeddah. My question about a patient has quiet disease by azathioprine, and incidentally found an ileocolonic fistula. It's totally asymptomatic. Do we need to go into aggressive therapy just for the sake of closure of the fistula, or we keep on azathioprine?
Asymptomatic fistula. If there's nothing happens. If there's no drainage from the fistula, if it's not a complex fistula, it doesn't involve the sphincter, or it's completely quiet, and even if it involves the sphincter, then I would do nothing. Yeah? There's no inflammation on the intestine, whatever, don't do anything. It's not going to be better with infliximab, or it's not going to be better if the surgeon operates. Ileocolonic fistula. Do nothing. If there's no inflammation or inflammatory mass around it, do nothing.
Thank you.
Yeah? If you have to operate the patient anyway, then I think it's a point to do this as well. But I won't do this, if there's really nothing else. But in most cases, you will have a stenosis, an inflammatory mass, and other things. And then obviously you have to act.
Thank you very much for your attention. I'm sure it was a very well informative session. Thank you, speakers. Thank you for the audience for staying and